On midterm assessment of 2030 Insight in Asia Pacific region and advocacy strategy for global summit for eye health. So if you are in the right session, then probably I think this is a hall you have to stay. Otherwise, so I would like to take this up. No, if somebody might have thought there is a cataract session or something. So my co-chair Yeni is not able to come, so I would like to invite Sujata, who is from Eye Care Foundation, on the stage to co-chair the session with me. And in the interest of time, I think we'll get started. And I would like to invite the first speaker is Peter Holland, who is the CEO of International Agency for Prevention of Blindness, and he's going to talk to us about the Global Summit and IPP Global Action Plan for 2030 Insight.
Thank you very much, Rohit. Excellent. I have some slides on the screen here.
Can you have Peter's slides?
There. I can see my slides. Oh, there we go. Well, thank you. Thank you again, Rohit, for the introduction. Thank you very much for everyone for joining us today. I'm just going to give a brief overview of the global situation before we move on to the assessment in the region. Can I have the next? I should be able to, yes. That doesn't seem to. Oh, there we go. So I think almost everybody will know who IAPB is, but just in case there's anyone with us today who are not sure, we're the overarching alliance for the global eye care sector. We're a membership organisation with now more than 250 members around the world, and drawn from the non-governmental community, eye hospitals, academic institutions, professional bodies, and increasingly the corporate sector and private sector as well. I'm sure you all know the scale of the global issue. This slide is obviously a reminder that more than 1 billion people around the world have sight loss because they don't have access to the eye care they need, and that number is growing. It's growing because of changing demographics, growing aging population around the world, the increase in non-communicable diseases, and increasingly the growth of myopia, which is obviously affecting younger populations as well. And so I think it's projected that by 2050, if we don't do anything about it, that figure of 1 billion will grow to almost 2 billion. And indeed, that doesn't really take account of the growth in myopia either. It's estimated that half the population will, of course, have myopia by then, again, if we haven't managed to turn the graph back the other way. And that has a wider impact. And again, I suspect this is familiar to everybody, that eye health is not just a health issue. It's an economic, a social, a development issue as well, and it cuts across a whole range of the Sustainable Development Goals. And I think increasingly that is recognised by the global community, that eye health isn't just a healthcare issue. It's an issue that affects education, it's an issue that affects employment, it's an issue that affects economic productivity. So the headline figure there is that eye health, the lack of eye care, the gaps in eye care leads to a loss in global productivity of more than $400 billion a year. Actually, that is likely to be a very significant underestimate. The figure is more likely to be in the trillions of dollars, but that's the one that we can absolutely reference. And we're developing at the moment a revised investment case that will update these figures, and we hope to publish that investment case in the early autumn, which will look at the impact on children's education, across economic productivity, and on people's lives more widely. Again, this is really a reminder. I'm sure many people have seen these and heard our slide before, but we developed with the global eye care sector, we developed a new strategy for eye health which we launched in 2021 to really move on from Vision 2020. And this had the very ambitious goal of eliminating avoidable sight loss by 2030. So that is our goal. That clearly is extremely ambitious, but it aligns with the Sustainable Development Goals, because the targets for the Sustainable Development Goals is around achieving those targets by 2030. And clearly, given the relationship that we've shown, you cannot achieve those Sustainable Development Goals unless you have eliminated avoidable site loss. We won't achieve the Sustainable Development Goals without eliminating avoidable site loss. So we've aligned our targets with that. That's why we've got that ambition of 2030. And overall, we want to see a world where no one experiences unnecessary or preventable site loss, and everyone can achieve their full potential. That eye care rehabilitation services are accessible, inclusive and affordable to everyone, everywhere, whenever they're needed, and that people understand the importance of caring for their own eye health and demand access to services free from the weight of any social stigma. So those are the key goals that we have, and in order to do that, we want to elevate eye health as a social, economic and development issue, incorporate it into wider healthcare systems, and drive patient and consumer and market change. We are making progress, particularly at a global level. We have seen greater global attention on eye health, starting back in 2019 with the launch of the World Report on Vision by the World Health Organization. That has been followed by a range of resolutions at the World Health Assembly, and importantly, the UN resolution on vision, which drew out this connection between eye health and the Sustainable Development Goals. And gradually we're seeing that impact on other areas. So it's been involved in the road safety resolution that the UN has passed, and in various other areas we've done work with the International Labour Organization to draw out the relationship between eye health and work. And right at the end, you'll see these references to the voluntary national reviews. So these are reviews that countries make on their progress on implementing the Sustainable Development Goals. And for the first time in the past couple of years, countries have actually talked about what they're doing on eye health. Four countries 2 years ago, 7 countries last year. And I think that is that shows the impact we're beginning to have and translating those global resolutions into action at country level. But there's a long way to go. This map shows, this is self-assessment for countries on the progress of integration of eye care into mainstream health services. So the first thing to note is that we've only so far got 47 countries reporting on this. So there's a big data gap that we need to fill in the first place. We need another 150 countries to report to do that. And then, as you can see from this map, there are very few countries that are reporting that they are successfully integrating eye care into mainstream healthcare. So there is still a big challenge for us in terms of really achieving the goals that we've set out to achieve. And that's why we want to hold a global summit on eye health in 2026. And these are the words of Aubrey Webson, Ambassador Aubrey Webson, who I'm sure many of you know, who is the ambassador of Antigua and Barbuda at the United Nations and has been a huge champion of global eye health. And in his words, the Global Summit on Eye Health is about turning words on paper to action for people, from paper to people. That is critically what we want. So our goals for the summit are obviously to champion eye health and shine a spotlight on it. Hopefully we can mobilise resources, but critically it's to galvanise national action. And that is the focus of what we want to achieve, is to turn those words, to turn the commitments that countries have already made at a global level into action at a country level. And that's what we hope countries will come to the summit to say what they will do. And it's essentially the start of a programme that they will do, so that it's not the end. They'll come and then we will have a roadmap and an accountability process that ensures the countries actually stick to the promises that they make. Thank you very much.
Thanks, Peter. I think what's the take-home message from Peter's? One thing I can take away is the ultimate goal of Global Summit is to take policies to action. So we have all engagement, we have all commitments, but how does it translate into action and implementation of the plans? I think that's most critical, because we have been talking and governments are committing, but I think we don't see the kind of commitment we see, that kind of actions are not, the translation into action is not there. So with this, I would like to invite the next speaker is Drew. Drew is the head of advocacy and policy at International Agency for Prevention of Blindness, and is going to talk about how he's going to do political and institutional engagement for the Global Summit. Drew, over to you.
Thank you very much to the chairs, and thank you to the audience for being here so early this morning. It's great to see you all. I would like to pick up exactly where Peter finished his presentation. So when we are talking about the Global Summit 2026, the Global Summit for Eye Health, just a reminder, if I can click through, of those aims and objectives that Peter mentioned, and picking up particularly on the idea of galvanising national action. As Dr. Rohit said, that is really the takeaway message there from Peter's presentation, is that the aim of the Global Summit for 2026 is to galvanise actions by encouraging our governments to deliver on the targets that they've already signed up to. Of course, also to bring new funders to the table, to champion technology and innovation in eye health, to agree an eye health roadmap and accountability framework for the next 10 years. The summit is a catalyst for sustained action. But in order to do this, we have to strongly engage with governments to ensure that they are part of the process, not only that they are attending the Global Summit in 2026, but also that they are part of the journey, that the journey begins now and it continues well beyond 2026, and that governments are engaged and part of this process. So how are we at IAPB undertaking this journey, and how can you, as the members of IAPB and the stakeholders of IAPB, be involved in the process? To begin with, we started to assess countries in our regions in a somewhat different way. We started to look at not only their eye health programs, but also started to look at the levels of influence that they may have within their regions. So if we have a look there, I've got Australia and Malaysia on the screen there, and we can see that we've started to map out where the power balances are. It's like a little bit like a checkerboard. So we can see, for instance, that Australia's involved in the South Pacific community, that it's involved in the Asia Pacific Economic Cooperation Group, and so on. We can see that Malaysia's also involved in APEC and ASEAN. We started to look at the language groups that countries look in, so that we can see how they also can start to map their influence across the regions. This was important to us when we were thinking about where to begin our targeting, where to start looking for champions. We then established a political and institutional engagement group. And you can see there some of the purposes, some of the actually quite lofty goals that we've set for ourselves. We want to ensure that at least 50 countries are participating in the 2026 Global Summit. We want to engage champion countries to promote the summit. So we're here in India this week, and we're talking to the ministry and many stakeholders about being champions for the summit. We want to ensure that groundswell of commitments from countries across all WHO regions is really strong and evident, and ensuring that there are national level opportunities and challenges are considered, so that there is a feedback as well to us and to the stakeholders in terms of what will be delivered by the summit. In order to do this within the political and institutional engagement group, we set up a structure, a committee that consists of the IAPB regional chairs, and then underneath the IAPB regional chairs at the global level, we set up a regional and national engagement groups. In many instances, of course, the national engagement groups are already existing. We know, of course, of organisations in this room like Vision 2020 India. We know that you have engagement groups in Nepal, in Indonesia, and so on. So it's not about reinventing the wheel. It's about finding ways to reach out to and engage those groups and ensure that they are understanding the information that is flowing from us about the summit, and also so that they can feed back information to the global group. The structure looks something quite like this. We have the political and institutional and governance group in the blue. We then have regional engagement groups and then national engagement groups. For those who are interested in being part of this process in this region, our regional chair, Dr. Rohit Khanna, is of course also the chair of the regional engagement group in the Sierra region, and Yuda and Indra, who are our IAPB leads in the region, are also very much a part of developing that regional strategy and talking to people in each individual country. I wanted to highlight an example of how this works from a region that is not represented in APAO. It's a relatively small country, and so it allows us to highlight the process in an effective way. We have here an example from Paraguay, and you might be wondering why there are tentacles hanging down from the top of the screen. That's because our friends in Paraguay decided that the model that we had developed looked a little bit like the tentacles of an octopus. You can see here that our friends in Paraguay mapped out the influencers and the decision makers in Paraguay. They included not only the IAPB members in the country, but also the members of various professional bodies. It included people within the Ministry of Health who they felt should know about the summit, but also could influence the government authorities to take decisions about the summit. Right over in the bottom corner is the Minister of Health, Dr. Maria Teresa Baran. And it was decided that in mapping the situation in Paraguay, she was the number one decision maker. It was Dr. Baran who could decide whether or not Paraguay would be a champion for the summit. And at the end of November last year, we went as a group and met with Dr. Baran, and yes, she agreed to be a champion for the summit. The first champion country in Latin America is in fact Paraguay. So that's how the program of national engagement for the summit will work. As I said, in this region you have a very strong leadership team in Dr. Rohit, in YD and Indra, so please reach out to them if you're interested in being involved in this political and institutional engagement process. Thank you.
Thanks, Drew. I think thanks for setting up the stage and the process for the entire selection of countries and institution for Global Summit. And I would hand over to Sujata for inviting the next speaker.
Thank you, Mr. Drew. Now I would like to call up on the stage Mr. Y. Sapkota to speak on the global target indicators. Mr. Sapkota is the regional coordinator for IAPB SCA region.
Yeah, thank you, Sujata, and thanks, Chair, and thanks to all the participants, distinguished guests, and delegates. So we have no, it's the wrong one here. No, you the Sapkota. Yeah, that's the one. Okay. I think we have had enough information of the Global Summit, and then this topic is a little bit different than the Global Summit. The first one maybe, but it's very much related. These topics, this data, the evidences I provide here is very justifying the need of the kind of the advocacy and the leadership required at the national level, which is the kind of the one of the objective of the Global Summit. So it's a global target, and the indicators on eye health has been set in the one of the World Health Assembly resolution in the 2021. We as the Peter mentioned earlier, we have had a very successful in having the kind of the global resolution at the global level and taking the endorsement of the government at the global level. But all those global things need to be translated at the ground level, at the national level, which is not happening as we wanted to be. So that is where the actual changes need to happen at the ground level, and then that's what we want to have a global summit. And then I want to show where we stand at the moment, since the 2030 is approaching very close. Now will be 5 more years to go. So the most important indicators what we are taking now at the moment, there are several eye health indicators has to be addressed, of course, and need to be improved. But the most important indicator which was endorsed in the WHO World Health Assembly was on cataract surgery and the refractive error, quantity along with the quality. That's we call it the effective coverage of cataract surgery and effective coverage of the refractive error, which is 30% increased from the baseline and in the cataract, and the 40% increase by 2030 in the refractive error, effective refractive error coverage from the baseline. So the country with the high baseline aim for the universal coverage, of course 70% or more goes to the universal coverage, and then only the national data may not be enough because there are the several population subgroup there. So the kind of the equity has to be also addressed in this indicator. That's what the WHO has mentioned. So why this indicator has been taken is these two indicators are the most cost-effective intervention. Could have been done easily in the past, but it's still a persistent problem we have and that need to be addressed. And then this is the most important, the bigger magnitude of the visual impairment and the blindness globally. And then also the huge unmet need in the cataract surgery is still there, and along with the refractive error. Therefore, the problem, the magnitude of the problem is increasing in the recent years and the years to come. So I will be more focused on the data and the information of the Asia region, because the Asia is globally almost more than 50% of the populations and accounted for more than 2/3 of the vision impairment problems. So when we said the indicator has been endorsed at the global level, but the country has to adopt it, but there is no adequate data to set the baseline for many countries. That was the kind of the issue. Therefore, the WHO has come up with the whatever available data to set the baseline as a reference baseline for the countries. So what it shows in the WHO reports in the global indicators is in a cataract surgery, that there are two threshold has been taken as a 612 and the 618 threshold. Among the 612 threshold, if you see the effective cataract surgical coverage, global median is quite low, is only the 17%. So the globally it has to reach by at least by the 30% point increase, means almost 50%, 47% it has to reach. And then similarly, if you take the threshold of the 618, it is a little bit better. The threshold means the need of the intervention for that purpose, the visual acuity less than 618 due to cataract, and then after intervention, the visual outcome become the 618. That is now that the current baseline is 24.8%. That's the way we stand. And then if you go to the this global median to the WHO regions, so we see that South Asia seems to be a little bit better compared to the other WHO region, but we could see that the big difference on the range in the countries. So the bigger range. Some of the country is doing well in the Southeast Asia, that means, and some of the country is not good, is far low. So though relatively among all the other WHO regions, South Asia is better, but the bigger range, because we have many countries with the big disparities. That's what we see in the 618 ECSC. And another issue which I wanted to show you here is the difference in the cataract surgical coverage and the effective cataract surgical coverage. There is a big quality gap we could see in this report. Even though the cataract surgical coverage, the people who have got the cataract surgery, that's the cataract surgical coverage, and with a good outcome is effective cataract surgery. There is a big quality gap we could see. In every WHO region. If we see here in the detail, what we could see that at the global level is the median global relative quality gap between CSC and the effective cataract surgical coverage is almost 34%. That means the 34% of the people who have had a cataract surgery have got the good visual outcome, 618 or better. That's the issue we have to address also at the moment. That's the where we stand. So we can see there are big differences in each regions. The Africa region is one of the highest. The quality has to be addressed on that along with the quantity. And then the Southeast Asia is quite slightly better, but it's still 1/3 of the cataract surgery hasn't got the good visual outcome, 618 or better. That's what this WHO report says with available data. Similarly, in the effective refractive error coverage, which we need to increase in a 40% increment point increase in the baseline globally, which is 35% if you take the 612, the refractive error is usually taken as, has to be a 6.6 or 6.9 good visual outcome, the very good visual outcome. If even we take the 612 as a threshold, the effective cataract surgical coverage at the moment is a 35.7% only. If it is taken as a 618 as a threshold, which is quite low, then we can see the coverage is 65.4% because mostly the refractive error visual acuity comes to between the 612 and the 618 need to be addressed because it's already you cannot drive and it's economically difficult. So if you see with the available RAP data, with the 50 plus data, if you see that the effective refractive error coverage, in the higher the age group, the less the coverage is there, and effective coverage also. So there is a quality gap issue also in the refractive error. The people in the refractive error, there are three kind of the met need, unmet need, and undermet need. So the met need is quite low, but there's a difference between the people wearing the glasses or wearing the appropriate correct lenses or not. That's also a quite issue. We see that in the Southeast Asia is not a big issue. Is people who have wear the glasses is almost wearing, and 3% of the people not wearing appropriate glasses, but it varies in each region. So the globally, if it has to be addressed, then this also need to be considered. So I'm showing some of the data which is available. That's the WHO data at the global level and the WHO regional level, and then the GBD level that they have analyzed and done the analysis. But when you see the country level in the Southeast Asia, many of the country doesn't have those baseline data individually. So they have to reference to the WHO average of that region. That's the kind of the issue we have to. The greener one is a kind of the available data at the moment, which WHO have used and the country can also be used. But you still see in the right side, the year is quite old data. Old data. You will only see that Nepal is the country who has the evidence of the visual impairment, EREC and ECSC data after the 2020. Otherwise, almost all the country in the world, in the Southeast Asia also still has to use the data older than the 2020 or even the 10, 15 years older data. If you see in the country, just the three line, look at the three line highlighted here, cataract surgical coverage, only if you take that as kind of the indicator, it looks quite satisfactory among the bilateral blind, among the people having the best visual acuity less than 360 is quite good in all these countries. But if you go to the WHO indicator, which endorsed in the World Health Assembly 612 or less, it's not much. First of all, the data is not available at the country level. And then only the Bhutan has available. That is also the 2017 older data, shows less than 40% coverage. And then the India has done the survey in the 2016-17, published in 2019. In the 612 level, it shows only 31%. And the Maldives slightly better, somehow, Maldives slightly better is above the 50%. If you see the Nepal, another available data is Nepal and Timor-Leste. Nepal data is quite recent. It's recently been disseminated, endorsed by the government, in fact, but the data survey was done in 2021, is 35%. And the Timor is another country where the data available is older data, of course, is 30%. So what we see here is in the country level, there is a paucity of the data. A lot of things need to be done to evidence generation. First of all, they set the baseline, and they setting the target is already issue. And then another issue will also come, we'll discuss later. Once you set the target, achieving the target is another issue will also be there. So these are the things we stand at the moment, and then the IAPB has kind of the focus country. If you cannot do in the all country at once, so we have a kind of the focus country. We are very much active in these two countries for this evidence generation and achieving those global target, how to go on a global target. So thank you so much.
Thanks, YD.
Thank you, Mr. Sapkota. Now I'd like to call upon Mr. Rohit Khanna. He is the Network Director at LP Prasad Eye Institute and also the Regional Chair for Southeast Asia IAPB. He will be presenting on 2030 Insight Update.
Good morning, everyone. So I'll just take a step back and give you an update. So YD spoke about, Mr. Sapkota spoke about the global targets, where do we stand and what's happening with that. But I'll just take a step back and give you an overview of the region, what's happening in the entire region in terms of targets as well as other issues which are happening in the region. So as you all know, Southeast Asia comprises of 11 countries, and all these countries are quite scattered across different, include from Timor to I think it's India and Nepal. And IPB came by this strategy almost more than 5 years, nearly 5 years back. During pandemic, after pandemic, they came with the strategy of three-pronged strategy, which is Peter spoke about: elevate, integrate, and activate. Basically, putting eye care as a developmental issue and also as in terms of educational issues. And YD spoke about all the documents which we had come up, and we were speaking about like these are all the resolutions which have been passed, and WHO came with multiple documents, and then probably I think there is a gap between the documents coming out and government using it and implementing it, and then probably that's the reason why we want to have a global summit, so that this all documents, all commitments translate to action. The first report on the global targets of effective coverage of cataract surgery and refractive error also came, which YD alluded upon, and we have the data on the baseline targets, but what next? How do we improve these targets? What do we do about it? I think that's something with $1 million question, because that's again how do we implement, how that each hospital, because it's individually has to be taken at the hospital level, and then only it becomes a country level data, and then only becomes we can report it. So right now we have baseline. Somehow we got the baseline because we were not using the 612 definition in the past, but we extrapolated, got a baseline. The data is being improved upon, and there are new data going to come this year about the cataract surgical coverage as well, as because as and when data comes in, they try to improve the data. So in IPB regional, we have these are a couple of priorities we did 5 years back when we were making the strategy. For the region, we made this following strategy, like increase political will and elevate eye health as a cross-cutting development issue, ensuring inclusion in major national health policy. So one thing was basically eye care, include eye care as a development issue and should be part of all eye care policies. Strong leadership to advocate for eye health and integration into universal health coverage. So this was another strategy. We wanted to integrate eye care into universal health coverage, and part of all the nations should take eye care as part of universal health coverage, and then they should formulate the national plan to in the line of reducing the avoidable blindness as well as improving the global targets on the cataract surgical coverage and refractive error coverage. And for the South Asia, when we were making the regional action plan, we included a diabetic retinopathy also, at the same time that we have to at least make sure 80% of diabetes are diagnosed, and 80% of those diagnosed are treated for sight-threatening retinopathy. So these were very broad targets where we want to use eye care. National health eye care should be part of national health policy, and government should integrate eye care into universal eye health, and also we should have a plan, and then subsequently there should be implementation of the plan. These were the 5 strategies, which is IPAC. I won't go into details of the IPAC strategies. This is basically a strategy document which can tell you that IPAC is a strategy which can be used to achieve universal health coverage in order to achieve our goal of achieving sustainable development goals. YD alluded upon the prevalence of blindness and visual impairment. These are the numbers keep changing, and we have data from almost all countries at different point in times, and now some data are old and we are trying to collect new data. And this was a strategy which was designed by the region for the regional action plan, which almost 2 years back, and we had this meeting which happened in Hyderabad 2 years back, where all the ministers of the region endorsed the plan and said that they would implement the plan. And then we went back, and now we want to look at what's happening with that. And when we looked at, this is the status of the plan. If you look at strategy plan, it's only there for Indonesia, and to some extent now Nepal has the plan, and some countries are in progress, like Sri Lanka is in progress. We've had a meeting 2 years back. So if you look at, you have good data on EXAT, effective coverage for cataract surgery, refractive error data is coming in, but the last 2 columns where you have a strategy plan and national endorsement, I think that is something which is lacking. And so that's with the commitment which was given almost 2 years back, 3 years back, I think has to be translated to action. And that's the entire reason that we need to galvanize our efforts and ensure that all the countries come and take this plan, implement the plan. I had a discussion 2 days back with the NPC, National Program for Control of Blindness India program manager, and then what he said was, we are still developing the plan. So I told, it's almost 2 years, why it's taking so long to develop a plan? So he said, we'll make sure that this year the plan will come. So probably we have to keep going behind them and talking to them that at least your plan should be there, and then it should be implemented. The plan should be implemented also. Country level advocacy is happening at different levels, and probably I won't go into details of the advocacy efforts, but at various levels we are trying to talk to different countries. We have the World Health Organization offices, WHO offices in these countries. We have IPP country representative in these offices. We have the national societies. Even trying to include the national societies as a member of IPP. We have All India Ophthalmic Society becoming member this year. We have Nepal Ophthalmic Society becoming member this year. So there are different societies because they are the one who are going to work and do action on the ground. The ophthalmologists are going to do action on the ground if you want to take care of cataract, if you want to take care of refractive error. We had optometrists, the vision technicians, the healthcare professionals. They have to take action. So probably we have to involve all of them so that the policies or the plan we discussed is translated to action. Widely alluded upon the 2030 Insight focus countries, and I think there is a lot of why these focus countries, because we felt that there are a lot of things which are working, a lot of conducive environment is there, a lot of synergies which are happening, a lot of we can use resources in these countries, and things are moving much faster and more comfortable and more conducive for us to navigate in the system and get things done. So at least show India was one of the thought which came up, but it was such a big country that each state becomes like a country. So we thought we'd start with small country and in the region, and then see how we cannot do everything in one go, but at least show how these countries have moved forward. So probably I think we took these two countries as an example, and I think we are making a pretty good progress, especially for Nepal. I will skip this. So I would like to all invite you for the 2030 Insight meeting, which is happening in Nepal this month, and probably all of you who have registered are welcome, but who are not registered would urge you to register for the meeting, because there are a lot of things going to happen. We are going to see a lot of action and probably a lot of things preparation for the global summit and what's going to happen next year. Thank you very much for your time and attention.
Thank you, Mr. Khanna. I would like to request Mr. Rohit Khanna to call upon the next speaker.
I would like to invite Tashi. Tashi is the medical officer at the World Health Organization, looking at the blindness, the vision program, the hearing. He has multiple hats, including drowning and road traffic accidents, and probably I think what he's going to talk to us about the regional action plan, what we worked for almost 2 years back. He's going to give you what was the action plan for, what was the action plan about, and then probably I will leave it to Tashi to tell the action plan.
Thank you, Dr. Rohit, and thank you very much, IPV, for inviting me to deliver this talk on integrated people-centered eye care in Southeast Asia region. I am Tashi, and as Dr. Rohit wrote, I work at the WHO regional office in New Delhi as the regional advisor for disability rehabilitation and injury prevention, which also includes road safety, drowning, and other portfolios. So eye health is one of the components that I look after, and this integrated people-centered eye care in Southeast Asia region, it is the strategic document of a region, not per se as a WHO, but it is a document that guides the member states, 11 member states of the region. That includes Bangladesh, Bhutan, Democratic People's Republic of Korea, India, Indonesia, Maldives, Myanmar, Nepal, Sri Lanka, Thailand, Timor-Leste. And this strategic document was drafted by WHO. Of course, I would like to acknowledge Dr. Rohit, who is the architect behind this document. And this is adopted by the member states to take it forward in their countries. This, I think, everybody knows that eye health is one of the most important component. And as Peter rightly pointed out, eye health is not just a pair of eyes. It affects the overall SDG goals. It affects the overall livelihood of the people. So therefore, it becomes very important for us to take care of the eye health. It also had an immense impact for my other portfolio, like road safety. So this eye health component cut across the wide range of the health problems that an individual gets. The numbers out here, this has been highly quoted by all the speakers. The important component out here is these numbers, behind these numbers, these are the real people. And these numbers, most importantly, are affects the vulnerable group of people. For example, like 55% of the vision loss are women and girls. And 90% of all that don't have access of eye care services live in the low and middle countries. And more importantly for our region, around nearly 30% of the world's blind and vision impairment population lives in the Southeast Asia region. So these numbers in the region are quite high. So therefore, we felt the need to have a regional strategy. Dr. Rohit also talked about these resolutions and targets. But I would like to again reiterate out here that these global targets is our collective targets. The resolutions are our collective resolutions. It's not a WHO resolution per se. It's a resolution that's advocated by all of us, NGOs, INGOs, and especially IAPB has been very active in these resolutions. If without your support, these resolutions would not have come in. And WHO was just a convening role at the Global World Health Assembly, at the global meeting, that ensure that these resolutions are there. And the key component is the resolutions at the 73rd WHO World Health Assembly, and then it resulted into adopting the 2 global targets, which YD explained about it in the WHO 74 resolution. And based on that resolution and the targets, the regional body, regional committee, which also convenes, its regional committee is a gathering of the 11 ministers, health ministers. And in Kathmandu meeting, they said, yes, we have the regional World Health Assembly resolution. Yes, we have the target. And we all know that 30% of the eye burden is on region. It is time for us to have a regional action plan. So that mandated the WHO Secretariat, as a secretariat, to come up with the regional action plan. And we worked out with our collaborating centers like LVPI, like Arvind and other stakeholders to come up with a draft document. And in 2022, at the Paro RC, they adopted the regional strategic plan. So the regional strategic plan, the overall vision is all people in the Southeast Asia region have equitable access to high quality, comprehensive eye health services to achieve the universal eye health by 2030. That aligns perfectly well with the SDG goals. That aligns perfectly with our global logo of no one leaving behind, with the mission to have a comprehensive, coordinated, and continuous eye hair care services for all ages with equal geographical distribution throughout an integrated people-centered primary eye care center. And Peter rightly pointed out, this integrated approach is the key word to have a successful, sustainable eye health care services in the world. And this also aligns very well with the primary health care approaches, the Astana Declaration that talks about the integrated primary, and then also the people-centered approach is very important. these global targets are well taught, but as Rohit rightly pointed out, in addition to the global targets, as the diabetic burden is increasing, we thought like it's very important for us to have a regional target on the diabetic retinopathy. So therefore, we included to ensure at least 80% of people with diabetics are screened regularly for retinopathy, and 80% those identified with sight-threatening diabetic retinopathy are treated by 2030. Still a lot of work to be done, but at least like this, setting these regional targets and global targets ensures that we work in a coordinated and harmonious manner. And also the other target was to eliminate trachoma in the region by 2025. Nepal, Myanmar has already eliminated, and in last year at the regional committee, India was awarded validated for the trachoma elimination as a major public health program, and this I think more or less ensures that the region is quite okay with trachoma elimination. And of course, some countries where like there are not cases, but elimination process was not done. But that doesn't mean that we have a lot of cases. So as I said before, the 75 RC resolution adopted the regional. The resolution not only adopts the strategic component, it also mandates the member states to act, and also requests the partners, international partners, INGOs, academicians, collaborators, to support and mandates the WHO to take forward some of the actions. So this is a very well coordinated approach. So therefore, it is our mandate, our accountability framework to work towards the common goal. The 5 principal. So this strategic document has like key guiding principles, the 5 guiding principles: universality, member state leadership, evidence-based actions, people-centered, leveraging technology. These are all relevant across the time span, and we have discussed quite a lot among it. And as Dr. Rohit rightly pointed out, we have 5 strategic priority areas. With each priority areas, we have actions and to develop to support the member states. And also the indicators and outcomes. These are all extracted from the global menu of indicators. And to get more insight into it, there are a lot of documents in the online. So the progress thus far is slowly progressing, as Dr. Rohit highlighted. A lot of trachoma has been one of the important ones. With India eliminating trachoma, it has been a major achievement. And situational assessment in most of the countries are conducted. Now the strategic plan is like most of the countries are taking up. For example, like Dr. Rohit pointed out, Sri Lanka, we are now is a final draft of the strategic document. Bhutan, we are planning to develop a strategic document, like situational assessments are already conducted. So the progress has been slow but steady in a very rightful direction. And the SPECS initiatives of the global SPECS initiative, the region member states have taken it up. And in our region, Bhutan, Nepal, India, Thailand, Indonesia, Sri Lanka are all taking up the SPECS initiative. And together with that, I think it will contribute towards our regional and the global targets. These are some of the documents as highlighted. A lot of WHO normative works are out here, and this is all available online for you to have a look at it. And this is the end, and thank you very much once more for IPB for giving us this opportunity.
Thank you, Mr. Tasi. Now I would like to invite Mr. Indra Sharma to speak on the IAPB ACA regional priorities and plan for 2030. Mr. Sharma, he is the IAPB ACA regional officer.
Thank you and good morning, everyone. So taking forward from all the speakers, I want to present the IAPB Southeast Asia regional plans and priorities for 2030. The strategies and approaches are all towards eliminating avoidable blindness and achieving the universal eye health. So just to summarize on what are the health challenges in South Asia, presently the high prevalence of avoidable blindness, limited access to eye care, inequity in health services, and the major cause, as we know, are the cataract, uncorrected refractive error, diabetic retinopathy, and uncorrected presbyopia. So by 2030, so what is that we want to achieve? It has been adequately highlighted. Is the strategy document of the IPV. I don't want to go to the details of this. So what's the goal for 2030? As a common goal is to eliminate avoidable blindness, and we will be helping by creating enabling environment and system change approach. And the key strategies involved will be to advocate and activate implementation of the IPC and 2030 Insight. And again, as highlighted earlier, to galvanize support for eye health to achieve the global targets. So our IPB strategy has also been adequately discussed. I don't want to go into the details of this. There are some of the priorities that we want our members and countries to focus on in the region. So one of the priorities is the evidence-based strategy. As it has been discussed, that there is a paucity of data. We don't have adequate data in the region. So data is actually driving policy decisions, resource allocations, and program evaluations. And the strategic actions, as Dr. Rohit and Mr. Yuta has highlighted, we need to strengthen the regional data on all the primary targets. And while doing that, we also need to utilize technologies and AI tools for making it more effective. The second priority is definitely services, strengthening the eye health systems. And one of the important tasks we have here is integrating the eye health into the national health systems. I think it's going to be a very, very difficult task, but I think that's what we ultimately need to achieve. Human resources are one of the concerns in the region. So training and distribution of human resources has also need to be prioritized. Capacity building, creating local leaders in eye health is equally important. We need to also continue developing the infrastructure, expanding the number of service delivery points. That's for the strengthening the eye health systems. Equity is another concern, as Dr. Tashi was also mentioning about the inequities in health services. So we have challenges in access, particularly for the marginalized population, the rural population, the females, the low-income communities. So the strategic actions, we need to have targeted outreach programs. We have a lot of programs, but we need now a targeted outreach programs, financial accessibility, and inclusive programs that involves everyone. Other priorities is definitely public health, promoting prevention and early detections. And our areas for focus for now is basically the cataract, refractive error, and diabetic retinopathy. Early detections, screening programs are ongoing. We need to focus more on the newborn children and elderly. The public health awareness has to continue, and people have to be aware of early detection and need for regular checkups. Definitely, strengthening partnership and advocacy is very important. We need to collaborate with more, we need more collaborations with the government, NGOs, INGOs, private sectors to increase the resource and the support. Policy and advocacy needs to continue. It has to go on, and we need to advocate now, not for making policies, but for implementing the existing policies. Innovation and research has to go on with the technology, and now with a lot of AIs and machine learning things, this should become a package of ophthalmology services. And we need to also promote telemedicines for remote consultations or treatments. Research areas, epidemiological researches are more required along the clinical researches. And low-cost interventions need to be developed. Innovative models for each countries, each districts, each areas has to be developed, because every country is unique in its own ways. In the meantime, while doing so, monitoring and evaluations are equally important. Tracking, the progress is equally important. So we have a lot of KPIs that we need to keep on track. We need to also establish the monitoring and quality assurance mechanisms, and also, we need to have some evaluation annually or biannually for regional as well as the national strategies. However, doing so, there may be challenges. Some of the key challenges highlighted here are the political commitments, which may lack. We may face resource limitations. We may have difficulties reaching remote areas. But in the meantime, we also have some mitigation strategies for that. That's the ongoing advocacy that we are doing at national and international level. We need to diversify funding resources for this purpose, as well as trying to expand the reach of mobile and telehealth services. So finally, in conclusion, yes, strategic plans and actions are required to achieve our common goal of reducing preventable blindness and increasing the access to eye health. And the regional plans and priorities also need to align with the global targets. So the call to action for now is urging our stakeholders, including the governments, the NGOs, the private sectors, and all eye health professionals to lend your voice and collaborate in achieving our WHO, IPC, and the 2013 site. We need to finally ensure that now eye health becomes an integral part of the national and national health policies, but also need to ensure that whatever has been made so far, the policies has to be implemented. I think that's it. I wanted to make it very brief in the interest of time. Thank you so much.
Thanks, Indra. I think it needs so brief and also eluding all the points. I would next invite Sujata Gautam. Ms. Sujata Gautam is from a Finance and Program Officer at iCare Foundation and working in Nepal.
Thank you, Rohit sir. Good morning, everyone. This is Sujata Gautam from Nepal, and I would also like to acknowledge my colleague, Mr. Anil Gorkhali. On behalf of my team, I will be presenting on the 2030 Insight, what we have come through so far and the way forward. So talking briefly about the eye care in Nepal, Nepal has an extensive eye care network. In the map, you can see the availability or distribution of eye care services throughout the country. We have a center of excellence, tertiary and secondary level eye hospital, and almost every district has a permanent eye care centers. There is sufficient but inequitable distribution of eye care human resource. Nepal is doing more than 300,000 surgeries per year and more than 4 million eye consultation. Cataract surgical rate is around 4,500. Over the years, substantial progress has been made to improve access to eye care service in Nepal. So this pyramid shows the tier of eye care system in Nepal. So at the bottom level, there is the eye care, community level eye care service, and then secondary level eye hospital, then tertiary level, and in the top we have the center of excellence, which includes the research and academic programs. You all are aware about this, so I won't go in detail since we are running out of time. So talking about the eye care situation in early 80s, the prevalence of blindness was considered as a significant public health issue. Eye care was in a very rudimentary stage since it was limited to very few government hospitals, and there was insufficient and uncoordinated human resources. And there was such a huge backlog of cataract that people who need the surgical intervention, cataract intervention, they need to travel all the way to India. So coming towards the 80s and 90s decade, then we adopted the public-private partnership in eye health. Many national and international organizations were invited to support and develop the eye care system in Nepal. Also, the geographical sector-wise public-private partnership model was adopted to ensure that the duplication doesn't happen while doing the service delivery. Development of human resources was created, which included mainly the mid-level eye care personnel, commonly known as ophthalmic assistant, and the MD ophthalmology and optometry program were introduced, which helped to create the extensive eye care network in the country. So with all these efforts in the last 4 decades, our major achievement is that we were able to reduce the prevalence of blindness by around 67%, from 0.84% in 1981 to 0.28% in 2021. Likewise, trachoma has been eliminated as a major health problem in Nepal. 2030 Insight in progress. Though there was significant reduction on prevalence of blindness by picking up the low-hanging fruits, but still we faced many challenges, mainly on the in terms of visual impairment and the emerging causes of blindness like diabetic retinopathy, glaucoma, uncorrected refractive error, and all these needs to get the attention. And also the eye care service and human resources were concentrated in the big cities and the flat areas, so the expansion to the remote and rural areas was very much necessity. So considering this, we needed a very effective strategy to implement, and hereby Nepal is committed in implementing the 2030 Insight Integrated People-Centered Eye Care, which includes the 3 strong pillars: elevate, integrate, and activate. So under elevate, we adopted multi-sectoral approach, and one of the good example of multi-sectoral approach is that we were able to eliminate the trachoma by empowering and engaging the people and communities. And we had the government advocacy efforts in SDGs, eye health included in UN VNR. Our Honorable Prime Minister participated in high-level meeting of eye health at UN. The meeting focused on raising the profile of eye health as fundamental development issue critical to achieving the SDGs. Further, as a result of the advocacy, Nepal recently included the eye health data under the UN VNR reporting system. National Eye Health Strategy focused on integration of eye care in pediatric, diabetic retinopathy, diabetic program and geriatric health program. Under this, government also made some effort, and we had the coordination with government hospital and medical colleges for the early detection and treatment of eye conditions, such as the coordination for neonatal screening services. Likewise, collaboration with eye care providers and other health providers was established to ease on the conditions, other conditions like diabetic, hypertension, and all that, eye injuries. Under integrate, we adopted the following measures. Eye health has been included in national health policy that envision the integration of eye care into the government healthcare system. National Eye Health Strategy has been developed and endorsed by the Ministry of Health. Eye health has been included in the National Health Insurance System. Eye care has been included as essential healthcare package. National RAP survey was completed in year 2021. National report on eye care situation analysis tool was published by Ministry of Health in 2024. Effective cataract surgical coverage has been included in National Strategic Health Plan 2023-2030 as a monitoring tool. And rapid assessment on refractive error survey is in progress. So under Activate, we have been celebrating World Sight Day at a national level to create awareness among the general people, political leaders, and the decision makers. People health-seeking behavior has increased through various promotional and awareness programs and integrated school eye health program. Under this, the school nurses are trained to assess the vision, and the vision card system has been introduced during the school admission. In this regard, Nepal government has implemented the School Education Sector Program, SESP, which emphasizes on the health priorities and mandating the vision checkups for school-aged children. So way forward. Despite substantial progress made over a few decades, we still need a lot to do. Nepal needs to further strengthen and continue these strategies to eliminate the blindness and visual impairment. Therefore, our focus remains on increased government prioritization towards the integration of eye health into general health, and the effective integration of eye health, including the integration of eye health data into the government data management system, IHMS. And all our effort and focus should be geared towards achieving the global target on eye health by 2030. That's all. Thank you.
Thanks, Sujata, for giving us an overview of a case study of how 2030 Insight strategy was implemented in Nepal. And lastly, I would like to invite Mr. Tulsiraj, who is the Director for Operations at Arvind Eye Care System and also Executive Director Emeritus for LICO, Arvind Eye Care System, to tell us about how the ground level action for WHO targets are being planned. So we had a meeting almost 2-3 months back at Arvind, and then we came with a policy document where how do we translate these targets into action and achieve our targets. So over to you, Mr. Tulsiraj.
Thank you, Rohit, and thank you for this opportunity. A bit of a repetition. WHO recently came up with two important indicators for cataract and refractive errors. I think what is unique about these indicators is that it kind of defined the intervention threshold, which I think is super critical, not only for defining the denominator, but also to compute how much work needs to be done. Now, otherwise, we just got prevalence data, which basically was a reflection of the work that was not done. And simultaneously, the indicator also built into it the outcome measures. So for the very first time, I think we have this wonderful combination of when to intervene and then what should the outcome be. This together, I think to me is a brilliant move. I think because for the first time, actually we can prevent blindness. Because this advocates that you intervene at an earlier stage. And then this is what I think will be very fundamental to even for IAPP to achieve its 2030 goal of eliminating avoidable blindness. Otherwise, we were focusing all the time on blindness data, and the focus was drawn to dealing with the blindness. That's a kind of no-win game. Why these indicators? I won't go into the depth because Sabkota talked about it in great detail. Looking at the current status, again a bit of a repetition. In India, if it comes to cataract surgical coverage, we are at about 36.7% effective coverage. And for refractive error, we don't have India-specific data yet. It's still being computed. Overall, we're at about 35.7% globally. And the goals are a 40 and 30% increase. There was some confusion, but it got clarified. What this really means is that 36.7 has to become 67%. That's an increase, and similarly for refractive error as well. In terms of ground level action, which is the focus of my presentation, we need to recognize that both these conditions, cataract or refractive error, with the exception of maybe myopia control, are neither preventable or self-healing, which means that we have to intervene to make it happen. Which means the entire action has to be at the provider level, whether it is case finding or making or solving this thing. So we essentially need to have two broad buckets of action that we need to engage in. One is to make sure that everyone who can benefit from refractive error correction or a cataract surgery is accessing care, that is active case finding, because not everyone is able to come to one of our facilities. And second is, once they come, we make sure that we don't misdiagnose or in advising, or having a low compliance rate, or doing good quality work. So all of that comes into the second bucket, which again is completely at the provider level. Together, this will result in a target achievement. Let me explain this with a simple example. So here we took the data of one hospital for a whole year, which had about 250,000 patient visits. And amongst them, when we applied this WHO criteria of best corrected visual acuity less than 612 due to cataract, 19,000 odd patients were eligible. And then when we looked at our own data, the EMR, which is fairly detailed, we recognized that only 44% of them were actually advised surgery, at least documented. Which means there's an advised gap of 56% as per the data that was available. Of those advised, 5,000 people got operated. Which again means there was a compliance gap of 40%. 40% of them didn't get operated. I'm showing all this to recognize all of these are under our control. Then of those operated, 90% followed up, the reasonable follow-up rate. And then amongst those who followed up, 80% of them achieved the desired outcome, either without correction or with correction. Okay. So when you compute all of this, what it results is then, as providers, we have achieved only a 19% effective intervention rate, different from coverage rate. That is, amongst those who came to us with a problem, we ended up giving only to 19% of them an outcome which meets the WHO goal. Now I just did a what if situation. If we just addressed 50% of the gaps, okay, we had a 56% diagnosis and advice gap. If we're able to address just half of it, then we would have advised 13,700 patients. And with better counseling and empowerment and removing barriers, if you could drive up the compliance from 60% to 80%, then the number of persons getting operated will go up to 11,000. Follow-up rate will not make a big difference, already there. And then if you're able to make sure that post-operatively we do good refraction, give glasses to all, we'll end up having about 9,000 odd patients meeting the WHO criteria of outcome, and then that 19% jumps up to 49%. Now, all of these are completely within our control of what we can do. So again, I'm placing before the argument that the opportunity for enhancing the cataract coverage or refractive error coverage rests largely with the providers. Of course, you need enablement from policy, government, some financing, all of those things are there. But ultimately, I think the ball is in our court. And then I also feel that all of us will be interested in this because it achieves the twin goals of altruistic, which is providing eye care to the community, as well as benefiting by it. Because when you intervene early, there's also increased capacity for the patients to pay for the services. So this is going to also result in institutional growth and resources as well. Thank you very much.
Thanks, sir, for giving an insight of how each hospital can contribute to the entire goal for achieving our targets for effective coverage for cataract and refractive error. With this, we'll come to end of the session. I don't think we have time for questions. But if there is any quick burning questions anybody want to ask, probably to anyone of the speaker, you're free to ask. But if there are no questions, then we can end this. Yeah, we can take one question.
I'm new to IAPB, but I'm very conscious of the great effort that IAPB has been doing over the decades. And I think you're right, we're all falling short of achieving the goals that we have, but that's what it's all about, that's what goals us. So happy to see about the cataract, diabetic retinopathy, a lot of effort being coming in, a lot of it concentrated in South Asia, Nepal, India, I think Indonesia is another, Southeast Asia is another component to it as well. An important part of preventable blindness, apart from that in young people, is refractive errors. And I think India has really taken the lead on that. And where refractive error comes in is prescribing glasses also prevents eye injuries in children. And to us, trauma is a very significant factor affecting children and young, productive, economically productive adults. So I think if we can integrate that into the preventable blindness agenda, that's something we can do that. And along these lines, I think Nepal is taking the initiative to organizing a great summit next year in ophthalmic trauma prevention advocacy we are involved in. We'd be happy to be involved and contribute. So thank you very much.
Thank you, sir. Thanks. And with this, I think I'd just like to call all the speakers to have a group photograph. You can stand here.